Welcome, everyone. Welcome today. I'm Andrea Scotti, Associate Editor of JACC Reports. I have the pleasure of having here today Dr. Richard Carrick and Drew Bidmead, who wrote a great article titled Conservative Management of Left Atrial Dissection and Associated Complete Heart Block Following Cardiac Surgery. First of all, I have to congratulate the authors for having this case accepted on both JACC reports and at ACC, where Drew Bidmead will present the case. So congratulations. And now let's talk a little bit about the case. Would you like to introduce yourself, Dr. Carrick?
Absolutely. So my name's Rick Carrick. I'm a cardiologist at Johns Hopkins in Baltimore, Maryland, specializing in non-invasive cardiology, imaging, and intensive care.
And my name is Drew Bidmead. I'm a third-year medical student at the Johns Hopkins School of Medicine.
Congrats, Drew. It's great to have a first author so young. This is what JACC Reports is encouraging. So we are very proud of this paper being led by you and with the mentorship of Dr. Carrick as well. So let's start by describing this case. Drew, would you like to tell us how this patient presented to your hospital and which kind of surgery they underwent?
Yeah, absolutely. I just want to start by saying thank you so much for the invitation and your interest in our case. So we have a 68-year-old male who presented to the emergency department 6 weeks following an extensive cardiac surgery. His presenting symptoms were sharp substernal chest pain, shortness of breath, and lightheadedness. And the surgery that he underwent 6 weeks prior included multiple parts. There was a bioprosthetic aortic valve replacement due to severe symptomatic calcific aortic stenosis. There was also a bioprosthetic mitral valve replacement for mild calcific mitral stenosis. There was an extended septal myectomy for hypertrophic cardiomyopathy, and for atrial fibrillation, there was a left atrial appendage ligation and a maze ablation procedure. So it was quite an extensive surgery, and the post-operative course notably was complicated by heparin-induced thrombocytopenia.
Excellent. So this was clearly a very complex case, very complex patient, and very complex procedure. So he presented to you with these symptoms, and then what was the workup you did in your hospital, and what did you find?
In the emergency department, workup started with EKG, which showed a first-degree atrioventricular block, and continuous telemetry captured intermittent symptomatic complete atrioventricular block that ended up requiring transvenous pacing. As well, in the emergency department, he received a transthoracic echocardiogram, which demonstrated that the bioprosthetic valves had normal function without any leaks or anything else, but there was a linear mobile echo density on the atrial aspect of the mitral annulus. So the main concern at that point was bacterial endocarditis or thrombosis. And so at that point, blood cultures were drawn. And once he was admitted to the ICU for the pacing, he underwent transesophageal echocardiography, which redemonstrated this echo density and further characterized it as extending from the mitral annulus to the left inferior pulmonary vein. And then a follow-up gated cardiac CT angiogram confirmed that there was a 4-centimeter left atrial dissection with contrast seen kind of interdigitating between this dissection flap and the rest of the atrial wall. And then this study also demonstrated that all 4 pulmonary veins were emptying freely into the left atrial lumen.
Excellent. Very, very interesting findings. So maybe we'll get back to you later. Drew, let me ask a question to Dr. Carrick. So this was a very complex case. involved, I guess, a very larger team. I can see infectious disease being involved, electrophysiology most likely, intensive care attendings, as well as heart failure, cardiac surgeon, interventional cardiologist. So this case is really involving so many physicians. How in your hospital do you manage this case and these discussions?
Yeah, we really pride ourselves in sort of a multidisciplinary approach, as you can imagine, in a complicated patient like this, where everybody sort of has to come to a mutual decision to figure out what the right next steps are for this person. So we do, lots of emails back and forth, group phone calls, and really the primary players were the ICU team, which is sort of myself and the other folks, the imaging team to make sure that we're interpreting the images properly, the cardiac surgeon who did his original surgery, and the electrophysiology team as we sort out what we need to do with his intermittent complete heart block.
Excellent. So, Drew, what did you decide and how did you manage these patients?
Our patient remained hemodynamically stable and afebrile throughout the hospitalization. It was also seen after about 6 days on continuous telemetry that the complete AV block was no longer seen. And so the pacing wires were removed and he kind of continued to have a heart rhythm that was not a complete AV block. And so because blood cultures remained negative, there were no clinical signs of heart failure or hemodynamic instability, like I mentioned. He was evaluated by our cardiothoracic surgery team, and it was decided that due to his history of heparin-induced thrombocytopenia, his clinical stability, and just general increased risks of repeat cardiac surgery, repeat sternotomy, the risks of going in and surgically fixing this problem seem to greatly outweigh the small benefit at the moment that would be conferred by repairing the dissection with a large second surgery. And so the ultimate decision was to opt for close follow-up with interval transesophageal echocardiography and clinic visits to check in on symptom progression or lack thereof.
Excellent. So briefly, just to summarize, this was a patient who presented with a complete heart block. He was found to have this left atrial dissection after this complex cardiac surgery. This complete heart block resolved after being monitored in the ICU, and then he was discharged with follow-up. How did you decide to follow up these patients after how long you scheduled the TE and the clinic visit?
He probably was in the hospital for about a week or a week and a half, somewhere on that order, and really was surprisingly stable given everything that was going on. And so the plan was exactly as Drew said. The next step was to repeat the transesophageal echocardiogram, primarily looking for extension of that left atrial dissection, which would push us more towards, needing to do that second surgery. And I think we did that around 4 to 6 weeks was the planned follow-up. The truth is there's not a lot of data out there on what the optimal guideline-directed management of a left atrial dissection is. So there was definitely a little bit of empiricism that we used here, just given how kind of clinically stable he was looking.
Absolutely. And this is why these cases are needed for these very rare complications, and the proper management in this case was very well managed. And also the discussion nicely presents how this complication can manifest. So this is one of the symptoms, complete heart block, but you also mentioned, and you stated before that this can occlude the pulmonary veins. Is that correct?
Yeah, so the main thing that would make this to be a more urgent or even emergent situation is obstruction. And typically that would actually be at the outflow of the left atrium. So impingement into the mitral valve apparatus of the left atrial dissection flap. But you could also have particularly if there's a kind of compressed hematoma that's contained within the dissection flap where that obstructs into the pulmonary veins and causes inflow obstruction as well. So basically anywhere that is preventing kind of normal blood flow obstruction is the thing that will precipitate this. The other thing that we can look for would be, true, through and through dissection where you get pericardial effusion, tamponade, sort of physiology, or even hemorrhage.
Excellent. So what are the take-home messages you like to give to the audience and all the readers of JACC case reports when reading your case?
Dissection does not necessitate repeat operation. And I think this case demonstrates that you can safely manage folk with a non-operative approach where you're kind of very close observation, repeat evaluation over time, as long as there aren't these sort of red flag hemodynamic compromise sort of pictures that you're seeing. And then the other thing that I think was a little bit kind of even more unusual for this sort of case was the association that we saw of complete heart block that came as a potential complication of the dissection, though also had extensive valvular surgery, so could have been secondary to that as well. But I think probably the left atrial dissection was sort of the icing on the cake on that and kind of precipitated the complete heart block at the end of the day.
Okay, let me ask you a question because this is very interesting. What do you think about this complete heart block being caused by the left atrial dissection rather than being an incidental finding as a complication after the cardiac surgery?
Yeah, I mean, it's a great question and probably one that we don't have a definitive answer for at the end of all of this. The timing, I think, is one of the things that is most suspicious to me about it. He was in the hospital post mitral valve, aortic valve, myectomy, Mays surgery, for a week plus, and didn't have any evidence of this. And kind of coming back in with his acute symptoms of chest pain and then kind of sudden development of these sort of shortness of breath, all of the timing sort of fits along with that. And one of the things that, we did when we were researching this case is that, in particular, there are right where that dissection flap happening was kind of the interatrial septum, the base of the atrial septum where the mitral valve apparatus sits. That's kind of right at some of the pathways of the AV node lie right there. And it's potential mechanical disruption on top of the original insult of the mitral valve surgery. So it's probably both were contributory, and then the dissection sort of kicked him over the edge into the full AV block. Would be my guess, but it's a hypothesis.
Of course. That's very interesting. So, Dr. Carrick, Drew, congratulations again. This was a very interesting case, and we are very glad to publish this on JACC case reports. Good luck with the presentation at ACC, and thank you again for considering us.
Thank you, Dr. Scotti. Really appreciate the opportunity.
Yeah, thank you so much.